Hey everybody, welcome back to the ECG of the day. My name is Reed, and don't forget that you can download a PDF of this document down in the description below. And don't forget that you can also like and subscribe to this channel to help support us if you want to see more, all the fun stuff. So let's jump into this fun ECG. So this is actually a patient who, for clinical context, has had 1 week of off and on chest pain with some associated diaphoresis, which just means they were sweating a lot, right? And so they come in, finally, they're stubborn, and their family was like, you need to go see the doctor, right? It's a 60-year-old female with, high blood pressure, diabetes, former smoker, kind of some vascular risk factors. And so you're looking at this ECG, right? And you're like, well, is this person having an MI? What's going on? But we know that we need to start off with our general idea of what we always do with ECGs, and we start off by looking at the forest. And so we look maybe at a rhythm strip, and I see I've got a narrow complex rhythm that seems to be very regular. Seems to be at a normal rate, but we'll calculate that, and it's regular for the entirety of the strip. If I find a QRS that lands on a solid line, maybe like this one, my rate would be 300, 150, 175, that's 60, so maybe 65 beats per minute, so that's normal. I see that there are some P waves in front of my QRS. It's reassuring. Let's evaluate those P waves, right? Let's look at the atrial activity. The P waves are upright in lead 1. They're upright in AVF. So it tells me this is a sinus P wave. So far we have a sinus rhythm. Let's look at what the AV node is up to. Remember, the AV node is, we can measure our PR interval. And so I find a QRS right here in the beginning of my P wave, and my PR interval is in between 120 and 200 milliseconds here, which is great. But we need to make sure that those PR intervals are staying the same the entire time, right? So I look through the rhythm and I see PR intervals seem to be consistent. And then I also look for any extra P waves that aren't conducted. And luckily I don't see any, right? So no extra P waves. So this is a nice sinus rhythm with good AV nodal function. Next thing I'm going to do is evaluate my QRS complex. We said it was narrow, right? The duration of this QRS is narrow. It's less than 120 or 3 small boxes, 120 milliseconds. My QRS axis is upright in lead 1, and it's upright in AVF, and so that tells me that my QRS is going down and to the left, which is normal axis, right? It's going nicely conducted down this AV node or His-Purkinje system, right? It's exactly how we want it to be. We look for good R wave progression, right? We have our little septal R wave that seems to grow a little bit and then transitions in V4, so that's good. And then we're going to look at our QT interval. Remember that QT interval, sometimes you can just take, an interval between two R to R's and make sure that the T wave doesn't really get to be past the midway point. We see that seems to be appropriate. Okay. So now we're going to look for our ischemic changes, right? What are our ischemic changes? Well, pathological Q waves tell me if there's been a prior myocardial infarction. That myocardial infarction could have been yesterday. It could have been 3 years ago, right? It just tells me that the myocardium is unable to conduct tissue in that direction, so we get deep negative Q waves. And then we have ST and T wave elevations and depressions that can tell me if there's any active changes, right? And we look for T wave inversions as a sometimes consequence. And so my eyes, when I look at this rhythm, really nothing is standing out except for my inferior leads. So I'll zoom in on my inferior leads. My inferior leads, remember, are leads 2, 3, and AVF, right? If I look over here on this chart, my inferior leads 2, 3, AVF. They are kind of representing the inferior portion of the myocardium. And I notice that I've got this Q wave. I've got that Q wave that's a little bit too deep. It's a pathological Q wave in lead 3, right? Don't have it so much here in AVF, right? You can see a little bit of it developing in AVF, but less so in lead 2. So if I look at my chart, that makes me think, well, if there was any injury, it would be to the inferior portion of the myocardium closer to lead 3, and to a lesser degree, AVF in lead 2, right? So if there was a vascular, infarct to a certain region of myocardium, that would be where it was. And I noticed something really interesting here. I've also got this kind of terminal T wave inversion in lead 3, right? Terminal T wave inversion. And the T wave is just a little bit what I would call hyperacute. Usually T waves are like this T wave. See how it's nice and kind of flat, and then you get a nice little hump at the end? This T wave, you can see it's kind of going up and under. So it's just a little hyperacute to me with a terminal T wave inversion. And so this pattern that you're seeing with the terminal T wave inversion is very characteristic of an occlusion that is kind of progressing through the infarct. So what does that mean, right? We know that we get initially, we get, an occlusion. What do we get? We get ST segment elevation. And then we, as things start to progress, that T wave starts to terminally invert. So this tells me, in the presence of these deep pathological Q waves in these terminal T wave inversions, that this person has likely been having a myocardial infarction for the past week. So this person needs to be evaluated. And so actually, what ended up happening is they went to the cath lab and they had 100% stenosis of the right coronary artery. We know that the right coronary artery supplies a lot of the inferior aspect of the myocardium. And so, unfortunately, this patient was having symptoms that wasn't concerning enough for them to come to the ER, and because of that, they had progression of their MI, and they were really unable to salvage a ton of the myocardium that was within the territory that was infarcted. So, terminal T wave inversions with some of those hyperacute T waves, especially in the presence of a pathological Q wave, should make you think that maybe this is a myocardial infarction that is just progressive, or that has progressed, right? And we're on sort of at the tail end of that. This patient did get a stent in the right coronary artery, so hopefully restoration of that flow did salvage at least some of the peripheral myocardium that wasn't as impacted. But yeah, this person is likely going to have complications of heart failure and cardiomyopathy in the future now that they've got this scarred myocardium, so they might have some newer symptoms as their heart progresses now, this kind of new decrease in function. So I hope this video helps you kind of understand a little bit more about ECGs. If it did, feel free to subscribe to the channel. If it didn't, if you have any questions, feel free to comment. So hope it helped, and see you on the next ECG video. Have a great rest of your day.